So this is lesson 2, inflammation. What is inflammation? Simply put, it's our body's natural defense mechanism. This is the way in which our body fights off any infection, any foreign body, anything that causes damage to our internal tissues and cells. So first of all, I'll talk about some terms that you need to remember. First, inflammation is of two types. One is called acute inflammation. Acute means sudden and immediate. It's an immediate reaction against any stimuli, such as an infection. So this is a form of innate immunity where it's not specific to a certain pathogen. In this, neutrophils are involved. Then there is long-term inflammation. That's chronic inflammation. That's a more specific reaction against, let's say, a persistent stimuli, something that's causing continuous inflammation. Next, the other word I want you to know is opsonization. That's basically, you take, let's say, a defense molecule. Okay, let's take an antibody. It goes and kind of tags a bacteria. This helps phagocytes and other defense molecules to identify and recognize and destroy it. That tagging is called opsonization. The molecule that tags it is called the opsonin. Now, whenever we learn any diseases, if a word has the suffix itis, I-T-I-S, at the end of the word, that is an inflammation. For example, vasculitis, cellulitis, dermatitis, there's so many examples. And next, PMNS, polymorphonuclear cells. That you break that word down. Poly means many, morpho shapes, nuclear, nucleus cells. So in our body we have three types. Neutrophils, which are the first responders in inflammation, they usually have 2 to 5 nuclei connected to each other by chromatin threads. Eosinophils, this is all histology, basic histology. They have earphone shaped nuclei. That's how I remember this. Eosinophils have earphone like nuclei, usually 2, and basophils have more of a bean shaped nuclei. And what's a granuloma? This was done in the earlier lesson, but this is granuloma is healing tissue. That is, new vessels, capillaries, platelets, white blood cells, they come to try to heal what was damaged. Next, I'll talk about some mediators of inflammation. First, you take cells and what they produce. For example, we take a cell, let's say a vascular endothelial cell. Now they have preformed granules. The production of these mediators are either preformed or newly formed. So when it comes to cells involved in that inflammation in that area, those cells might have preformed granules. For example, histamine. And some cells that release histamine that have these granules are mast cells, basophils, and platelets. Next, you have newly formed substances that is produced when needed, usually in response to a stress due to, let's say, the infection. These molecules you will learn more in immunology, but I will just tell you these. Prostaglandins, leukotrienes, PAF, plasminogen activation factors, ROS, reactive oxygen species, nitrous oxide, this is secreted by macrophages, and cytokines. Next, we have some proteins which are produced by the liver. These are also preformed proteins that circulate in our blood. First is complement proteins. For inflammation, we just need to know these three, and these three functions. You will learn what complement proteins are in the first lesson of immunology, as I remember. So first, C3A and C5B causes the release of histamine, the degranulation of histamine from cells such as mast cells. Then C5A, it attracts neutrophils, MAC, membrane attack complex. Again, membrane attack complex. It goes and it creates a hole in the membrane, allowing water to go inside and cause the cell to swell and burst. Then we have C3B. It also does a similar function, and these are also opsonins for phagocytes. Kind of tags these damaged cells or the infective organism and calls phagocytes. Next, factor 12. This mainly includes two substances, bradykinin, vasodilators plus pain. It's a very potent vasodilator and a mediator of pain, and some coagulation proteins. So first, I'll talk about the 5 cardinal signs of inflammation before I explain what inflammation is. There's 5 signs you see when a patient is undergoing inflammation. It could be a localized inflammation, or it could be a whole body inflammation. So first, fever. That is because bacteria or whatever infecting organism can release some substances called pyrogens. Pyro, it's a prefix for heat production, in the sense fire. So these pyrogens are taken up by macrophages and cause the release of interleukin 1 and tissue necrotic factor, TNF, and that causes an increase in cyclooxygenase in the hypothalamus. That COX will break down into prostaglandin 2 and cause the normal body set temperature to rise to a new one. So the next cardinal sign is swelling. That is due to edema. Now the first response of our body is vasodilation. That is to send as much fluid to the place of inflammation as quickly as possible. Third, redness. That is because of vasodilation. Fourth, pain. Bradykinin, prostaglandin E2 and histamine causes the sensitivity of pain receptors to increase. So even a small stimuli can cause these receptors to activate and the patient will feel pain. And the last, it's the loss of function. The person cannot do the normal functions that he usually does, he or she, or that area cannot perform its usual functions. Let's say the kidney cannot produce urine in its normal way. Next, we are going to talk about 2 tests that are used to measure inflammation. Now this, I will simplify this. The first one is called erythrocyte sedimentation rate. This is something like a drip test, a water drip test. Let's take a tap and you allow water to drip down, and you take how many drops dripped in a unit time. It's a very similar mechanism. This involves blood. So the thing you need to know is erythrocytes, red blood cells, are negatively charged, so they repel each other. Now, let's take this diagram, the first diagram, and we see that in unit time 10 red blood cells will drop down. 10 red blood cells will drop down, and there is going to be separation between these because of the negative charges. And if you were to, this is just if you look at the blood, you will see that these cells are separated from each other at a certain distance. Now this is all hypothetical, just for the sake of explanation. Next, in a state of inflammation, or in a state where there is an increase in ESR, so let's take inflammation, there is going to be an increase in fibrogen. Fibrogen is produced by the liver, and the fibrogen is going to kind of hang on to red blood cells. It's going to be stuck on red blood cells. That will decrease the negative charge of the red blood cells, and you will see the red blood cells are more closer together. Again, there's no real way to see this, except this is a very hypothetical diagram just to show you what happens when ESR increases. That because the negative charges decrease, the negative repulsion is going to be less, so more red blood cells will fall down in unit time. Because the repulsion is less, more red blood cells will fall down. So you get an increased ESR in inflammation, anemia, infections, cancer, pregnancy, and renal diseases. The main one you need to know is in inflammation, the ESR increases because fibrinogen will go and kind of get stuck on red blood cells. Next, I will talk about a decrease in ESR, how that happens. This is mainly because either the negative charge of the red blood cells have increased or the cell size has become smaller or abnormal. First example, sickle cell anemia. Next, we have polycythemia. This is an increase in red blood cell. Next, we have heart failure, microcytosis. So what is microcytosis? That's the size of the red blood cell has become small. And finally, we have hypofibrinogenemia. Low fibrinogen anemia. This is a condition. So in this case, because either there's increased negative charge, or because the cell size is smaller, these cells will fall at a slower rate. So these are the three. That's the first test in checking for inflammation. The next test is something called C-reactive protein test. Now, C-reactive protein is a protein produced in the liver during inflammation. This acts as an opsonin, and this is very important. This is not a specific sign of inflammation. It's a very non-specific sign. That's basically saying it doesn't tell that your kidneys are what's inflamed. It just tells that you have an inflammation somewhere in the body. So how do we check for inflammation in a clinical setting? One, erythrocyte sedimentation rate. Next, a C-reactive protein test. And this is the concept behind those tests. Now I will talk about acute inflammation. So what is acute inflammation? That's an immediate response. It's non-specific, immediate, it's a very fast response. What are the causing factors of acute inflammation or any type of inflammation? Infections, trauma, necrosis. This is because of dead cell debris accumulation or foreign bodies. So just for the sake of everything, explaining and all, I'm going to use this symbol, this hexagon, to indicate all of these. So what is the hallmark of acute inflammation? It's neutrophil accumulation, and also edema happens. But if someone asks what is the hallmark of acute inflammation, you need to know that it's the neutrophils. These are phagocytes which accumulate. I will take the changes that occur into two parts. First, changes in the blood vessels. So let's say there is an inciting factor. Okay, here's the inciting factor, the stimulus that is going to cause damage to the cells in this area. If it's a bacteria, it's going to produce cytotoxic chemicals which will damage these cells. And what happens then is that the blood vessels dilate. The blood vessels, the capillaries in that area will dilate. Sorry, not the capillaries, arteries will dilate, arterioles dilate, and this vasodilation, along with an increase in endothelial permeability, is going to allow fluid containing a lot of proteins and cells, what we want here is neutrophils, to leave the vessels into the area where the let's take an infection, where the infection is. So this fluid is a very high protein rich fluid. It has a lot of proteins, so therefore this is called an exudate. It has a lot of proteins plus cells. So if you were to look at it, you will see a very white, it's colored. And the other type, you will have to compare this in several subjects, including diagnostics. You need to differentiate between exudate and transudate. So what happens is, many people make the mistake of switching the two. They do not understand, they forget what exudate is and they forget what transudate is. An easy way to remember this is, just remember that trans has it's a prefix for transparent. So just remember, transudate is clear fluid. That is mainly due to abnormalities in osmotic balance. It's usually water leaving the tissues. This could be because sodium goes out first, and as I said, water always follows. Sorry, the audio cut off. So over here, I'm going to explain the difference between transudate and exudate. I need you to understand that trans, the front part of that word, it means transparent. Exudate is protein rich fluid, it has color. Transudate, it's transparent, and this is usually due to abnormalities in osmotic balance. Now what do you mean by this? Okay, so if you remember, I told you that water can leak out of a cell. Also, I told you that whenever sodium goes somewhere, water also goes behind that. So remember, transudate is due to abnormalities in osmotic balance, while exudate is due to increase in proteins and cells. It's usually an inflammatory reaction due to an infection. So the best example here is, you do CSF testing, cerebrospinal fluid testing. This is very important in diagnostics, and what this entails is, you take a sample of CSF and you kind of check the color. If you see it has a whitish color, or if it's yellowish, you can say that there is an exudate, there is an infection happening in the spinal cord or the brain. So next I'll talk about what happens to the neutrophil. Okay, more of what are the receptors that are involved in an immune response. This will be explained in the pathway, but I just want you to know, neutrophil has several receptors, including toll-like receptors, TLR, CAMs, cellular adhesion molecules, integrins, and a molecule called Sial-Lewis X. Now TLR joins with PAMP, and the CAM molecules also join with CAM molecules which are present on vascular endothelial cells. Now the things on the left are what's present on the neutrophil, and things on the right are what you find in this case in the blood vessels, the endothelial cells. Integrins will join with CAMs. Sial-Lewis X will kind of get attracted. It's not going to be a physical hold with selectin molecules. Now let me explain the process of neutrophil migration. Okay, so next we are going to talk about neutrophil migration to the site of infection. First, what happens is, the area in front of the inflammation, where the infection or where foreign bodies or trauma is going to, the area in front of that, the blood vessels are going to dilate. These blood vessels dilate. So when the blood vessels dilate, the neutrophils are kind of pushed more towards the margin, and when they touch the margins, they start to roll. Now these neutrophils are now rolling along the surface of the endothelial cells, and in front of where the inflammation is, those cells are kind of told to express selectin molecules. Now selectin molecules are more like road bumps. So when these molecules hit these road bumps, they are going to slow down. So when neutrophils are kind of attracted by these selectin molecules, they are going to slow down. They continue slowing down, and at the region where the inflammation is, they are going to it's going to undergo a process called adhesion. This is done by cellular adhesion molecules, ICAM, which is going to hold on to a molecule called LFA. Now the ICAM will kind of push the neutrophil inwards like this. The neutrophil is going to be pushed inwards, and it's going to be held by PECAM1s. It's present in both the neutrophils and the vascular endothelial cells. It's going to kind of push it towards the inside to allow it to cross through. And then over here you can see this neutrophil, it squeezes through inside this area where it has to go, and chemical substances released by the bacteria is going to cause an attraction towards the neutrophil. Is going to be attracted towards those chemicals. It moves towards those chemical agents, and this is called chemotaxis. I'm going to talk about some chemicals released to cause chemotaxis. Some examples are C5a, interleukin 8, LTB4, leukotriene B4, and bacterial products. And this is it's the USMLE first aid diagram for what was explained before. Margination and rolling. Selectins are going to be road bumps, and it's going to be captured by ICAM molecules, pushed inside with the help of PECAMs. Next, I'm going to talk about the types of acute inflammation. Before that, I want to give you this diagram. This is very important. Like I said, edema happens first. Edema is going to be the first response, because vasodilation and fluids and proteins leave first. Next, neutrophils come and they do their function. They go destroy everything. They can find which is abnormal. Now till around 2 to 3 days, neutrophils dominate. They run the fight. So after this, if there is signs that this inflammation is not going down, monocytes, macrophages continually accumulate there, and the neutrophils undergo apoptosis. They die. They are not taken back into blood. Once they go into tissues, they will die in the tissues, and the monocytes, that is basically mononuclear cells, will take up the chronic inflammation. So acute inflammation, it can either resolve uneventfully, and these are some types of inflammation that can occur. Serous inflammation. Serous means cells are low, more fluid, and you can see this in spaces like the peritoneal cavity. Next, fibrinous inflammation. In this, there's a lot of fibrin deposits, and this is seen in diphtheria. So this diagram over here, in this you can see the mucosa layer that is undergoing necrosis. Those cells are dying because of this inflammation, and on top of this, a cap of fibrin is going to come and deposit. This is called a pseudomembrane. that is going to lead to the formation of a scar. When fibrin goes and deposits in excess, that area loses its function. It becomes a scar. So the next type is a purulent inflammation. In this, cells are high, especially neutrophils, and the hallmark of this is pus. What is pus? It's an accumulation of neutrophils, liquefied debris, and edema fluid. Now I will take two types here. An abscess. So what is an abscess? Abscess is basically, there's a wall. This is a wall produced mainly by fibrin in an attempt to contain the inflammation in one place. It's a confined region. This occurs because of either the infection seeds into a tissue or secondary activation of infection, like an infection in necrotic tissue. So what you find in the middle is pus, basically yellowish pus containing neutrophils, debris. I think you might have had boils. So that's an example of this. It's a confined region, and when you break it off, you can see the fluid coming out. Now that's called an abscess. The next type is a spreading type. This is seen in phlegm that you produce when you cough, and signs that there's an infection is if the phlegm is clear. Let's say you have a cough, you have a cold, and the phlegm that you produce is clear. It's because of it being a viral infection. But if it becomes cloudy or yellow, that means a bacterial infection has come on top of the viral infection. So a doctor usually asks this question: what color is your phlegm? And depending on the patient's response, the doctor decides if the patient is going to be given antibiotics or not. Next, another type of spreading inflammation is something called cellulitis. This is an inflammation of the skin involving both the epidermis and the dermal layer. Now, when a patient comes to the doctor, so let's take this to be the arm of the patient where there is an growing cellulitis present. You basically see all 5 cardinal signs in this. So what the doctor does is, the doctor is going to draw a border and ask the patient to come back in 3 days. And how does the doctor decide if it's cellulitis? Within 3 days, this has spread outside the confinements of the border. This is a very common presentation in hospitals, cellulitis. It has spread outside the border that was drawn. And when the diagnosis is confirmed, usually the patient is given penicillin for around 30 days, high dose penicillin for 30 days. Another type of its inflammation is called an ulcer formation, when not only the epidermal layer or not only the top layer, it involves bottom layers. It can go all the way till the muscle layer of the mucosa, and this is seen in gastric ulcer. It's like a punched out region. This is like a punched out. You punch it inside a bag, you get the shape that you get. That's how similar an ulcer looks. So quickly I'll go on to chronic inflammation. Chronic inflammation, the hallmark is macrophage accumulation, and in this type of inflammation you do not see polymorphonuclear cells. All the cells you get are mononuclear. So macrophages accumulate. In addition, you get new lymphocytes, also a mononuclear cell. B cells, T cells, those are examples. And chronic inflammation is a prolonged inflammation. It happens over a long time, and it happens either after an acute or it can happen on its own. This is a condition where inflammation plus tissue repair coexists, but neither is able to completely finish its job. And this is a more specific defense mechanism. So next part is a granulomatous inflammation. Now this is a type of chronic inflammation where the T cells have a persistent response to certain infections. This is an attempt to wall off the resisting stimuli, but it cannot remove it completely. Again, this is a T cell response to certain infections to wall off existing stimuli, but cannot remove it completely. There's two types. Caseating, very similar to, this is what happens in caseatic necrosis. In the middle you get central necrosis, and it's seen in TB and fungal infections. Or it can be non-caseating. There is no central necrosis. This is probably due to this is a very specific group of diseases, such as a foreign body accumulation, such as metals. Let's take a bullet wound, for example. If you don't remove the bullet, you can get a granuloma in that area. I'll explain that a bit more later. Crohn's disease, it's an autoimmune disease, and cat scratch disease. There's more, but these are the main ones. So let me explain what I said about the bullet wound. Let's say a person is shot and the bullet goes and pierces the liver. So if you do not remove the bullet, what's going to happen is there's going to be an inflammation. Obviously, it's a foreign body, our body cells are damaged, so our body goes and attacks it. It tries to get rid of it, but it cannot. So what it does is it walls off the bullet. It walls off the bullet in its attempt. There's going to be cells and everything, fibers, deposits. They try to wall off this bullet, but it cannot. Now the difference between this and caseating necrosis is the bullet does not fight back. There is no fight back from the bullet. But TB and fungal infections are going to fight back. So when our body attacks, it's going to fight back by producing its own substances. And what happens is they're going to kill each other, and in the middle you get central necrosis. Easy way to remember that. The bullet, it does not attack back, it's just there, and our body tries to get rid of it, fails, so it walls it off, and there's no central necrosis. Now the way this happens is first the antigen is presented. The antigen is anything that is part of the infecting or whatever that is damaged. So antigens are going to be presented by these types of cells called antigen presenting cells. Some examples: dendrocytes, neutrophils, macrophages. You will learn in immunology. They go and stimulate CD4 plus T helper cells, and they release interleukin 12, activating these T helper cells. Now what is T helper cells? They are basically the ones that call the others to come help in inflammation. T helper cells will release interferon gamma that is going to activate macrophages that will cause the macrophages. This is very important. These macrophages become a type of cell called epithelioid. It's going to form a type of cells called epithelioid cells. You can see it here. So that's basically a macrophage, but involved in granuloma formation. And these cells can kind of accumulate together to form something called a giant cell. You need to know these two types of cells. Again, fibers come and deposit to wall off the inflammation, and this fibers are produced by fibroblasts, so you get them also. And in the middle you will find the inciting factor, which I drew in purple here. Now that's what a granulomatous inflammation is, with caseating and non-caseating. Now, healing. Healing initiates immediately with inflammation, because substances like fibrinogen, they all come to try to repair the damage. Healing occurs by two methods: regeneration and repair. Cells are of three types, but one type, permanent cells, cannot regenerate. These are permanent cells. So the examples are nerves and muscle cells. So if they cannot undergo repair, because they can't regenerate, they can only undergo repair, they will die. So again, if a nerve is damaged, they can repair, but they cannot produce new nerves. If those cells die, or if the injury is too much, it's going to be replaced by a scar due to the loss of stem cells. Let's take a deep cut. There's two types of healing. Now the first type of healing is one, let's take a cut in the skin. You suture the wound up to bring these edges close to each other. And on the edges, I'll draw this part again. On the edges, you have stem cells. They are going to create new tissue and fill this space up. And this is important. Healing by primary intent is one where you suture the wound, you approximate the wounds together, and you allow it to heal by itself with minimal scarring. There's going to be minimal scarring in this. However, in healing by secondary intent, you get a deep wound, a large wound. Now the stem cells will be present only in a small region. It can't cover this whole wound. So what happens is, fibers come and deposits. Fibers including collagen, they come and deposit. There's going to be some sort of repair, but the main thing is fibers come, and this is going to form a scar. Now if the deposit does not stop afterwards, if there's going to be excess deposits even outside the confinements, it's going to form a huge scar, and this is called a keloid. And finally, this is the same thing. When repair by cell division alone is not possible, fibers deposit, and if a normal scar is formed only by type 3 collagen, which is organized straight molecules and confined to the borders of the original wound. But if type 1 and type 3, if the scarring occurs excessively, fiber deposit occurs excessively, type 1 and type 3, which is very disorganized, and it's going to create an excess scar which is not confined to the original borders of the wound, and this is seen in people with dark skin mainly. Finally, these diagrams. As you can see, this is a purulent inflammation of the brain. This is a meningitis infection where there is pus produced. You can see the purulent exudates, neutrophils and everything. Purulent appendicitis. This is the normal appendix. This is, you can see the difference. This is acute inflammation of appendix. Compare the colors. Neutrophils have so many nuclei that it's going to look really purple. You can see the neutrophil accumulation. Bronchopneumonia, these are called abscesses which are formed. It's confined. You can see the border clearly. Here's the abscess with the border, and this is a boil, pus. Also, this is red. That's an inflammation sign, and this is an ulcer. You will learn this in GI pathology. The difference between acute inflammation and chronic inflammation can be seen here. These cells are all neutrophils, while in chronic inflammation, these are lymphocytes, these are macrophages. You can see the single nucleus in those. Caseating granuloma. Here's the border. This was the border, and in the middle you get dead matter. That's central necrosis. Non-caseating granuloma. You can see the epithelioid cells, and you can see the giant cells. It's also confined. You can see the border, and that's it for inflammation.